Professor ENT, and I am presenting the lecture Tonsillitis. Today I will teach you tonsillitis. Now, what is tonsil? Tonsil is the palatine tonsil. It is a paired structure of lymphoid tissue located in the tonsillar fossa between anterior and posterior tonsillar pillars. Now, what are the functions of tonsils? You can see the diagram here. Here we can see the tonsils in the tonsillar fossa, and here is the anterior pillar and the posterior pillar. Now, what are the functions of tonsil? It is actually a immune system's first line of defense against ingested or inhaled pathogens. You see, when we go out in the atmosphere and we get lots of anti this pathogens which attack our body through mouth, so it protects us from against them. These are the first line of defense. It contains the crypts on the surface that increase the surface or surface area and increase the efficiency of protection against pathogens. Then it is the inner part of the Walder ring. You get to see we have a Walder ring in which there are these lymphoid tissues are arranged in a ring form. This adenoids are one of them. It produces B cells, T lymphocytes and antigens presenting cells which support the providing immunity. Now, tonsillitis. It is categorized into acute and chronic. What is acute? Acute is of four types: acute catarrhal, acute follicular, acute parenchymatous, and membranous. And chronic is acute chronic follicular, parenchymatous, and these are the pictures you can see. This is our chronic parenchymatous. Now, what is the etiology? Acute tonsillitis most commonly affects school-going children, but is also seen in adults. Chronic tonsillitis is a consequence of repeated attacks of acute tonsillitis and due to inadequately resolved acute tonsillitis. It can be of bacterial and viral origin. Bacteria that cause positive agents are group A beta hemolyticus streptococcus, Streptococcus pneumoniae, Staphylococcus, Haemophilus influenzae, Bordetella pertussis, Moxella catarrhalis. And in viral are the influenza virus, adenovirus, Epstein-Barr virus, paraffin influenza virus, herpes simplex virus, enterovirus. What are the clinical features? What they present with the features in our OPD. These in acute we get to see sore throat, pain during swallowing, high grade fevers with chill, body ache, generalized weakness and earache. Why earache? Because of the nerve supply. What are the chronic clinical features? It is recurrent attacks of sore throat, dry cough, chronic irritation in throat, difficulty in swallowing, halitosis, apneic episodes at night. Any single this feature can be presented in the OPD. Clinical signs, we get to see what we elicit in the patient. In acute, we see the congested and edematous tonsil. Then hyperemia of pillars, soft palate and uvula. Crypts may be seen filled with pus and with swollen follicles in follicular tonsillitis. Diffuse swollen tonsils can be seen in parenchymatous tonsillitis. Whitish membrane may be seen in membranous tonsillitis. Then tender cervical lymphadenitis. Tubulodigastric lymph nodes present here at the angle of mandible. They are tender and large. But in chronic, we get to see hypertrophy of tonsils, persistent congestion of anterior pillars, halitosis, and cervical lymphadenitis, but non-tender. What all investigations will do? We send the throat swab, complete blood counts and ASO titer, X-ray of tissue for nasopharynx to see the lymphoid tissue at nasopharynx, that is called adenoids, and extraparanasal sinus for sinonasal septic foci. We can go for medical treatment and we have to go for medical treatment in acute tonsillitis. Penicillin group of choice, antiseptic gargles, analgesics, antipyretics, etc. And first of all, we have to maintain the hydration of the patient. Now, surgical management. Tonsillectomy, in chronic tonsillitis, we have to go for tonsillectomy, and it has two type of indications. That is absolute and relative. Absolute is recurrent infections of throat, 7 or more episodes in 1 year, 5 episodes per year for 2 years, and 2 weeks or more for lost school or work in 1 year. Then peritonsillar abscess, absolute indication for after 6 weeks. Then tonsillitis causes febrile seizures, causing airway obstruction, interfering with speech, and suspected malignancy. Now, the relative ones are the diphtheria carriers not responding to antibiotics, streptococcal carriers who may be the source of infection to others, chronic tonsillitis with bad taste or halitosis, unresponsiveness to medical management, recurrent streptococcal tonsillitis in a patient with valvular heart disease. What are the complications? Are the chronic tonsillitis, peritonsillar abscess, parapharyngeal abscess, tonsillolith, cervical abscess, acute otitis media, rheumatic fever, acute glomerulonephritis, subacute bacterial endocarditis. These are the pictures you see: peritonsillar abscess, tonsillolith in the tonsil. Thank you so much.